Hi, how are you? I'm Sergio Mota. I'm um, I'm glad to stay here and explain to you this the case about the problem. And it's to me it's very difficult to talk about this, to talk the problems because the ethical compromise. Um, but I know it's important for us dentists to work with implantology to do what happened and the way you try to fix it in and what's the care you need to don't have more problems in the futures. Then we really talk about the complication. This in complication is happen and then I can classify them intraoperative problems. Can see then the first slide, it's the first pictures is implant inside the body, the mandibular, uh, or you broken the mandibular in the same space to try to remove the graft, the bone graft, or early post-operative, it's you did this orthodont movement and then introduce the implant and then begin to do the restoration, the static restoration. It's it's bad. Um, Not possible to do this good results about the statics. You need to maybe to be back to do everything and new everything again. And the late postoperative problems can lost the implant, lost the graft, the herpes of the bone, and maybe it's happened if you think this. You can classify the problems with this light, moderate, severe, and deaf. Fortunately, deaf it's not happen frequently. It's I do the review about this paper, and I feel little bit about its problem. And it can do the classificate about this problem with these biological problems, infection. Can see this remove the tooth, introduce the implant with the graft, of allograft, and the graft lost because maybe the infection is too high, and then you didn't do this good analysis about this when you remove the tooth, and maybe you need to wait and oh, it's happened. The equipment, I think it's the worst problem is you don't use the guides, don't planning um, about you do the good guide, and then you can see then the implant position and the palatal position, or the median space. It's very difficult to do this using these implants to do the prosthesis. You can see this case can for possible to do the process, but initial the patient thinking the use the removable process removable, but remove parts, but you can see the implant position. It's impossible to do the over the enter something else. You can't pay to the fixer because you're not planning uh, first. And receive the crow of the technicals, the lab, and then you can see the rust finish and polish and accompaniment, this the metal and ceramic. You have this problem in the futures. Um, Mechanics problem. Today, it's normally to introduce implants in the body and the bone. If you do the key, not to use the mount implant, then in this way, if you have some problem, try to retrieve it. Then it no possible. Sometimes you can see this one, and can see the lateral access to remove the implant. And the situation with the statics, you can see this. You I need to in the aesthetics, I think it's mandatory you do this CT and then everything it's possible, scanning pictures, because and remove the tooth and can see there is external reservation, and put the temporary and to cicatrization and you back no bone. Then sometimes the patient use sold the treatment with the patient with introduced implant and don't need to tell your patient, oh, I need to review your planning because no bone, you need to do the graft. It's bad, very bad. But if you focus only this problem and the patient, only the division, the professional human factors about this. I have one factor about this patient and the professional. Now I talk maybe about the professional. And Samara did this organ about this errors in restaurant and errors due to manufacturers. And can see the latent errors and administration, manager, equipment, and problems with you chose the equipment and chose wrong and planning wrong something, and then your routine. Then I think it's interesting to review this paper and the topics about this. Then really, you talk now in this moment about this, what happened really. You can see the implants inside the body of this the mandibular bone. If you need to think what happened, you need to back and then do the review about this anatomy. You can see this draw about this when you have the teeth, and the tooth it's in this area, the first molar. You have the glandulas, you have vases, nerves, and so close the roof, and it may be you need to have excellent quality of your hands to introduce the implant at the same moment and remove the tooth. It's very difficult, and you need the excellent planning about this CT, about this analysis, the quality of the bone, and it's very difficult. Uh, I think it's easier for me to remove the tooth, waiting 60 days, and back and introduce the implant. But when you introduce the implant, sometimes your cortical bone it's not you don't have enough thick, and you don't cicatrization is not so good about this, and you normally maybe introduce the implant in bad conditions. It's quality of the bone, not cicatrization of the bone, but the bone it's soft. Then you need to think what kind of implant to introduce, the techniques you can use it. You see this in the blue, the area blue. You can see this. The best moment. It's you have this thick cortical, and you can see the side in the mandibular. Then the normal focus on it's the chose the implant. Today, I think it's everyone knows the best implant is to the crow one unit crow. It's using the connection, internal connection, Morse connection, and platform suite. Depending on the kind and the model of the implant, you can have this screw with without the microroscas can see that. And this case, you can introduce the implant, and the company and told you can introduce implant 2 millimeters interval inside the bone. Uh, if you have bad quality of the bone, so you don't have cortical, maybe it's not good attitude to introduce this. And this model implant can see then they have more rotation because you have screws micro screws and this and the neck then protect it then can you give in the more contact the bone. But the company told for you now you need to do uh, CT analyze the quantity of the bone, and if you have a quantity, you introduce the implant using the protocol and put 1 or 2 millimeters inside the bone. Then this way, I think it's the best. And if you see then, uh, it's the perfect. And the draw is perfect. You put the implant and put the implant inside the bone. It's compacted 2 millimeters, connection platform suites, cone Morse, perfect. It's nice condition. This decision about this chose the implant, just what system I use, and depending the profession. The professional like to use this internal connection platform suite, the left side, or this way, this X connector X, and then parallel board. I I think it's both. It's good, but both have problem. And then, but today if I prefer to use the first. Then the company told you you need to do this sequence the burst, and then you can see that you can use this for to do the implants. And but normally this protocol is a relationship with this the D1 D2 bone quality. Then you using the words it's coming the calibration and do this surgical values, and you have the protocol of the company introduce implant, you have fix and contacts enough, perfect, you do this. You can introduce them bone level, or you can put inside the bone, depend on the model, the contact model with the prosthesis and your philosophy about this. And then this is the sequence this company can. But if you have a quality of the bone bad, um, maybe you can think about this using the hybrid implants. You don't do this countersink, and then you only it's compression this the bone, compression the medullary bone and compression the cortical bone. You need to analyze your CT. Then it's I think this kind of the implant platform suite Connie Morse. It's interesting, but in this case, this company don't use this hybrid implant. The implant is one bod, and I think it's using the compressive techniques and sub-instrumentation techniques. It's interesting in this case. And can use in the first words to in the depth and off, and then sub-instrumentation the valves. Because when they introduce the implants, it's compression this wall, and consequently you have more contact and more stabilization then. I think it's good for this kind of implant you can see then. Then the way you have a stabilization, contact bone, and perfect. But you need to analyze. You can see then. I think something happened in this and during the surgery, and I think it's the professional try to introduce more implant, and it's lost your control about this. and in this case, it's implanted inside the bone. Then, if you don't feel well the bone, don't feel well the techniques, maybe it's interesting you chose the modeled implant. I think you can use an implant if a guy HL, uh, your body it's small than the neck, or you using the conomorphs, but um, conical form and the subinstrumentation. I think it's nice to use them. Then it's perfect the planning the professional you do the CT, analyze the size of the implant, the diameter of the implant, and then do it and then formulate the implant inside them. Then now I analyze what happened, but really I don't know what happened. But I think it's this summatory of the problems do this case. And what I did, it's easy. It's not so difficult. And to do this incision and relax, then you can see the lateral wall and open the windows with the board is 701. Remove this lateral bone. You can see the implant. Can see then the body, and you pick up this implants and remove them. You can see it's easy, very easy. It's no blood enough. It's possible, and you can see them remove. In this case, the patient prefer to only close your windows. We did it. With this case, you can put the lateral wall and the same place, the same, and cover with this biomaterial and the membrane and to close it in. The patient prefer don't do more surgery, don't do the implants. He prefer to do the bridge, this fixed bridge about this. It's nice. It's perfect. There's no worry about this. Can do the both. This way, it finish waiting 20 days and remove the sutures and the patient as well. Then I will reinforce if you need to review your concept about this surgery and then the time you spend on to do this implant and the problems you can give them. But you explained for you about I think it, but maybe it's have different you think. Then in this case, I think it's but conclusion. Um, your decision, your excellent planning, analysis, CT, analysis density with the house field equipment, and can see then and decide what model the implant you can use and the technique that you use in food quality. The bone, it's D3 or D4. Then you need to share with your patient about the risk, and then he's agreeing with you. Then thank you very much about this moment and stay with you and invite to if you wanted to do the course advanced mentoring and course direction to the 1 or 2 perfection no more and we can choose what kind of the implant of kind of the surgery you like it to do your level stage to grow up your practices in implantology. Then thank you very much about this moment we stay with together, and then I hope you like it. Thank you.